Good afternoon, everybody. Welcome to the VCU Department of Internal Medicine Grand Rounds. Today is May 19, 2022. And today's session is sponsored by the Division of General Medicine here at VCU in the Department of Internal Medicine. Today's session is about storytelling in medicine. The topic is race and medicine. Before I introduce our speakers, I just want to go over a couple of housekeeping items. We are still in a hybrid approach for grand rounds. We have 3 more grand rounds for the rest of this season before we take a summer break. For these sessions, they are recorded, are available on the website, and can be viewed with the link. The CME code will be posted in the chat again now and then at the end of the session. The QR code for new innovations will be available at the end of the session as well. We want to thank the Division of General Medicine for hosting today. And a quick reminder that we still have the Grand Round survey that's open until tomorrow to provide us some feedback for next year. Consider filling that out at the end of the session. I'll put the link in the chat in a minute. So without further ado, I want to go ahead and introduce our speakers. Today's topic, storytelling in medicine, race and medicine. Our speakers today will be Dr. Megan Lemay. She is an associate professor of medicine here at VCU. She went to medical school here at VCU and completed her residency at Yale New Haven Hospital. She practices in general internal medicine and addiction medicine and is a core educator in the internal medicine residency and addiction medicine fellowship. Dr. Sarika Moody completed her undergraduate degree in biology and religion at the University of Georgia and moved to Birmingham to complete her medical degree at the University of Alabama. She came back here to Richmond and is now an academic hospitalist at VCU. Her academic work focuses on the passions of improving healthcare disparities, health inequity, fostering diversity and inclusion in the residency program, and service in low resource areas. She has led global health trips and worked with 3 clinics since her time as an undergraduate student. She's currently the Associate Program Director for Global Health and Health Disparities for our internal medicine residency program here at VCU. Dr. Wally Smith, he's a professor of medicine, vice chairman for research in the Division of General Internal Medicine, and a former scientific director of the Center on Health Disparities here at VCU. He was a member of the Institute of Medicine's Committee on Standards for Trustworthy Guidelines and has authored over 100 publications and served as an investigator on over 50 externally funded grants and contracts, including being a principal investigator on 26 federal or foundation-funded grants and contracts. He's an experienced implementation scientist and really an expert in clinical and health services research around sickle cell disease. We have 2 community members with us today. Ms. Kathryn Mejia, she's the program manager of professional services at Therapy Brands. She has a long career history working in behavioral health and hospital administration with a focus on process improvement, patient experience, and mental health awareness. And lastly, we have Ms. Bangura. She is a George Soros Equity Fellow with the Open Society Foundation, a WPA Fellow with the United States Department of Arts and Culture, and served as chair of Richmond Region Tourism BOK RVA Initiative, as well as the City of Richmond's History and Culture Commission. She's an independent historical strategist and social entrepreneur here in Richmond, and has been credited as the originator of the International Commemorative Justice Movement. Her work focuses on ancestral remembrance and reclaiming memory culture by preserving memories of historically Black neighborhoods. In 2013, she founded Untold RVA and Untold Tours to inspire non-traditional audiences with bold typography, audio-enhanced street art, and urban exploration. I want to welcome all of our speakers, and we look forward to hearing you all tell your stories as we learn more about race and medicine. Thank you so much. I'm going to turn it over to Dr. Megan Lemay. Thank you.
All right, thank you so much, Dr. Berman. I am so thrilled to be bringing another storytelling medicine grand rounds today. The theme today of today's stories is race in medicine. I'm honored to be able to present today with Dr. Sarika Modi, Dr. Wally Smith, Ms. Free Bangura, and Ms. Kathryn Mejia. So why is the first slide in a race in medicine grand rounds the picture of two little white boys? These are two of my sons who are home with COVID currently. So I am presenting to you live from COVID Central with no one else to take care of them. So I must ask for a little bit of your grace. They have been bribed with every screen and piece of sugar in this house not to interrupt grand rounds. But if they do, I just apologize in advance. Okay, so let's get to the work. Today we hope to discuss race as a social construct rather than a biologic variable, to review the current use of race in medicine, review the personal experience of patients and physicians related to race in medicine, and to compare and contrast race-based versus race medicine. Before we begin, I just want to say we, especially I, am not an expert in this area. I am not a person of color. I'm not a physician of color, and I truly don't wish to put words in the mouths of our patients of color or physicians of color. I am but someone who thinks this is an important topic and has tried to educate myself about this because I think it's my responsibility to do that. And we also want to acknowledge others are the experts. There are decades, centuries really of work in this issue, and we're honored to be able to present some of that work today. I also hope today we can agree to acknowledge bias and avoid defensiveness when presented with new or challenging information. We all have grown and learned in this country and this medical system that was really built with racism baked into it. And there is so much to learn about this issue. I also want to acknowledge that it has been an especially horrible week for racism in our country. And I hope we can utilize today to help join this charge that our university gives us, not just to end violence, but to play our roles in ending racism in our community, including the medical community. So when we think of race in medicine, what do we think of? When we are considering race in a clinical context, do we assign physiologic or biologic importance to a patient's race? I'm going to turn it to Dr. Modi to talk more.
Thanks, Dr. Lemay. So first, when we talk about race and we talk about race in medicine, I think it's important, like we do for all science things, is let's define our terms. So what does race mean? I asked this question because I think it's really important for us to recognize that race is a somewhat ambiguous term. It's imprecise. And as such, it's really hard to use race in medicine. Throughout the years, medicine has, in general, thought of race as having biological importance. At least that's how it started. And when we think about the history of race, it becomes clear that this biologic importance doesn't actually truly exist, that it's much more of a social construct. So when the first time white race is mentioned in literature or something and things like that is actually in the 16th century. And it was actually meant to refer to Anglo-Saxon people from that origin. However, with immigration and people of different races and colors coming, there was a threat of power. And so because society at that time wanted to keep a certain group of folks in power, they started using white race to really mean people of European ancestry. And then we see that interplay happen in the US colonies when we have enslaved people who are being enslaved and treated inhumanely and using race as a justification for that. At that time, in the 16th, 17th century, you have the Enlightenment theories bringing on ideas of evolution and hierarchy, and race was kind of tied directly into that. And people at the time believed that race was a biologic important thing that could help justify treating people, a whole group of people, inhumanely. And so race is really tied to power and keeping power in society. And we can see that as it's developed. Now, in the 20th century, we've done a lot of genetic studies and in anthropologic studies. And what we found is that the genome actually, between socially constructed racial groups, the genetics are actually pretty much identical, 99.5 to 99.9% identical. The actual variation you see is greater between two people who are in the same race versus two people in different races. So again, kind of really honing in on that point that race is actually much more of a social construct and not a biological importance. Now, the question is, how do we use race in medicine now? Well, I would argue that because we still have race in our medical calculators in the way we've even calculated GFR up until recently, you can see that race has been used as this biological significance, and we treat patients sometimes accordingly. We give certain medications based on their race. The other question that often when I talk about this we get is, well, what about sickle cell disease? Isn't that tied to race? Well, I think that what we have to ask ourselves is phenotypic race a proxy that we can use for ancestry? And the truth of the matter is, when population genetics looked at this, they saw that there really wasn't any data to support that race was linked to a mapping of certain areas coming from certain areas. So really, that sickle cell disease is really more prevalent in societies and communities of people who had ancestry from places with malaria. That's really the true connection, not necessarily race. The other question I would have to ask, I think as physicians, we all have to ask ourselves is, when you make those clinical decisions based on race, how are you identifying somebody's race? When you walk into that room, what are you using? Because I can tell you that I myself have been misidentified as Hispanic, as Arabic, and I'm Indian. That's how I identify. Yet somebody look at me could not necessarily say that for sure I'm Indian. And I think, again, when we use race in medicine and we identify somebody else's race, we're really just picking out one part of their ancestry. We don't truly have an idea of what their true genetic makeup is. Next slide, please. So let's talk a little bit more about how race has been used in medicine. Again, this is a very broad overview. This is a huge topic. Whole degrees are based in this, so I'm not going to be able to really do all of it. But let's talk a little bit about the history. So when emancipation happened, enslaved people were emancipated, but they didn't have any resources. They weren't given any food, shelter, healthcare resources. There's no institutionalized structure for them. And as you can imagine, when folks are emancipated but without any resources, you saw lots and lots of death in these communities. And so between 1860, I can't read my numbers, but between those years, you see that millions of requests for medical assistance from emancipated people were quite high, and that lots of people during that time had high rates of mortality. And based on this, doctors at the time assumed that there was an inherent weakness in the Black race, and that made them more prone to sickness and death. And so this assumption that there was some sort of biological significance that made these people weaker and more prone to death has been kind of baked into the system of medicine that we even practice in today. And because of that, doctors at the time made the argument that resources shouldn't be used really for these patients because there was already an inherent weakness in that. Then we get to the idea, so then the Freedmen's Bureau was established, and this was established basically during Reconstruction, and it was a way to try to combat and give resources to these people who are newly emancipated. It was a really great thing to have done, but it also established this idea that Black people are getting healthcare in a different setting. This history is long, and we actually have here at Chimborazo Park in Richmond, if you guys are familiar with that, that's actually where one of these open air hospitals existed, led by Rebecca Lee Crumpler, who was the first woman physician in the US. And she ran that part, but what was true of it was that it was severely underfunded, had very little resources, and again, this idea of healthcare and it being segregated developed essentially. And so this segregated unjust healthcare system developed in the US. Desegregation didn't happen until 1965. And here at MCV, we had St. Philip's Hospital, which I'm sure some of you guys have heard of. I have patients that tell me I was born at St. Philip's or my parents were born at St. Philip's. This existed up until 1965. And the only reason that MCV desegregated was that Medicare was passed. And that's true for all hospitals across the US or all healthcare systems. And that was because funding was tied to desegregating these healthcare systems. So really, the way we even provide healthcare, you can see, has really been tied into race very much. And so this is really just bringing home that point that racism is the reason that race exists. The need to create a power structure to really mistreat and discriminate against a group of people. Racism is the reason that race exists.
Thanks, Dr. Modi. So understanding that race is a social construct without real biologic significance, how are we using it in medicine? This is a study from not too long ago, from not too far away in UVA, just up the road, where they asked medical trainees about their beliefs about biologic differences between Black and white people. And you can see that many of the trainees held false beliefs, including that Blacks age more slowly than whites, that Blacks' nerve endings are less sensitive than whites, and Black skin is thicker than whites. When they then presented these trainees with patient cases, the trainees that held these false beliefs were more likely to not administer proper pain treatment to Black patients in the cases. How are we propagating this myth in our medical training? In a review of the pathologic basis of disease, there were 31 mentions or associations between race and an illness. Meanwhile, most of those associations could not be proven anywhere in literature. In a review of real-world questions, where they examined when race was mentioned in a question stem, they found that when Caucasian was mentioned, it was merely incidental in the question, whereas when African American or Native American was mentioned in the question stem, it was much more likely to be considered essential to the diagnosis of the patient in the question. So what we're doing by linking race and disease in this way is inferring, implying, even if we're not saying it out loud, that certain races are predisposed somehow biologically to disease, when that just isn't the case. How are we using this medically in clinical practice? These are all just a few examples of medical calculators that include race as a variable and return a different risk for disease based on a patient's race. The ASCVD risk estimator returns a 2 to 5 times higher risk of disease if the patient is listed as African American. The FRAX tool, there are different calculators for FRAX in North America for Black patients, Hispanic patients, and Asian patients, which return a lower risk of hip fracture and osteoporotic fracture compared to Caucasian patients. Spirometers in the United States all have a 10 to 15% correction factor applied to values from Black patients in the United States, which leads to the underdiagnosis of lung disease in our Black patients and probably under treatment. Meanwhile, research just from a few months ago sort of bears out that applying those race corrections to spirometry values do not help us predict correctly chronic lower respiratory tract events in our patients. I hope that all of you may find the time to read this article, Hidden in Plain Sight, about the use of race correction in clinical algorithms, where they argue that when clinicians insert race into their tools, they risk interpreting racial disparities as immutable facts rather than injustices that require intervention. And they argue that the inclusion of race in these algorithms can further exacerbate inequities. So for example, in the FRAX tool, when we know that Black women in the United States are much less likely to be screened and treated for osteoporosis and have much worse outcomes if they suffer a hip fracture, if we're utilizing this calculator to make treatment decisions for low bone density for our patients, that leads to less treatment of our Black women patients, that will further exacerbate an inequity. Dr. Modi.
So we see that there are medical calculators and medical studies that have used race in a way that sometimes that seems to have given race a biological significance. And what we see is that there are outcomes here that are truly very terrible in medicine. So we see these terrible health disparities. Studies have found that Black people between the ages of 45 and 54 die of strokes at a rate that's 3 times greater than their white counterparts. Black or African Americans are almost 4 times more likely to have kidney failure compared to white Americans. And Black or African Americans are 30% more likely to die from heart disease. Now, I think the question that we have to really ask ourselves here is, if race isn't the reason for this, then why do these disparities exist? And I think that that's where we start realizing that it's racism, that it's that discrimination and those social determinants of health, those structural issues that have been there for a long time. And those are the reasons that we see these disparities.
What about the racial makeup of our medical system, of our physicians? I was quite sad to learn that the percentage of Black medical students did not increase between 1979 and 2020. Meanwhile, the National Academy of Medicine asserts that increasing racial and ethnic diversity among physicians would improve access to care and life expectancy for minority populations in the United States. One piece of good news I can share is that from 2020 to 2021, enrollment of Black medical students actually increased by 21%. So what Dr. Modi and I have attempted to do is to provide you a really sort of high-level 10,000-foot view overview of what is a really important and complicated issue. What we really hope to do today is to deepen all of our understanding of this issue by listening to and understanding the narratives of people who have experienced it. So that's one reason that I'm just really honored today to be able to bring you these stories. The first story is from a friend of mine, a community leader and activist, founder of Untold RVA, Miss Free Bangura. She could not join us live in person today, so we were lucky enough to have her record her story for us to hear. I'll play it for you now.
This is Free Bangura. I'm the founder of Untold RVA, as Megan shared, Dr. Lemay. And I wanted to come today to give you guys a little context about myself. And my experiences in the medical community that I think reflect some sort of systemic inequity attached to me being a Black woman. And so what I do for a living, I think, is an interesting part of this, because at the time upon which my incident occurred, I was cooking. I had my own vegan food business. It was called Veggie Love. And I had, a few years after this incident, won Vegan Iron Chef in the city of Richmond. But right now, I've moved on in my career, and I'm 10 years into this project called Untold RVA. And it's a hidden historical consultancy that helps dismantle the systemic racism within our historical record, using sacred street art and tactical urbanism and making changes to the built environment. So as you can see, I'm a person who knows their stuff. I won Vegan Iron Chef back then when this story actually happened, and I was able to defeat River City Vegan, Ipanema, Harrison Street Cafe, Whole Foods, and Elwood Thompson's head chefs. So I've always just had a sense of being confident about the things that are my skills, talents, or abilities. And so the story that I want to share with you is about when my third daughter was born, and she's now about to turn 14 this month. She goes to Benford and here in the Fan, and she's lived in Richmond her whole life. Richmond is my hometown too. But by the time she was born, I already had 2 daughters that were 14 and 15, I think, either 13 or 14, and 14 and 15. But those 2 girls, one was born at MCB, the first one, Pascal, And then the second one, Ari, I was traveling in Maryland, and so she was born there. And then the third daughter, Ngozi, is the one that we're talking about. This is her birth story that I want to share with you. So I guess me being 34 at the time when I got pregnant with her, it was a prophecy that was given at my godfather, my spiritual godfather in New York. He passed away doing spiritual work with one of my god sisters. And I was up there for his ceremonies, and the priests were saying that someone in the room was going to give birth to a child who was going to hold all of the responsibilities, the spiritual responsibilities and cultural responsibilities of that family and take them to the higher level. And that child was going to be blessed. And so I was laughing at my god sisters and brothers in the basement that day. And I was like, one of y'all is going to get pregnant. And it's not going to be me because I'm about to move back to New York. I'm going to move to New York and go to Brooklyn College and study music therapy and all this. This was, 2007. And then when I got home from that trip, I took a pregnancy test. Her father and I then found out that I was pregnant with her. And I was just like, I cannot believe it was me. So, being an older person, 34 years old, and having had two children back to back in 1994 and 1995, I just didn't expect to be using my body for pregnancy again. And I found out, I guess, maybe 4 or 5 months into the pregnancy that I was going to really need to be on bed rest. I think it was like 4 months that I needed to be on bed rest, and that my cervix was already thin. So I went to my OBGYN or my obstetric appointment on the weekend of Memorial Day in 2008. And we had just received notification that we had to move. Our landlord was selling the house, and the bank came by and said, look, we'll give you $3,000 if you leave and leave everything perfect. I was like, but I'm about to have a baby. I'm supposed to be on bed rest. So I'm still trying to pack. When I go into this appointment on Memorial Day weekend, the doctors said, you're going to have to stay because this baby is so close to the edge. Your cervix is like non-existent at this point. You've got to stay in the hospital. So I asked them if I could just go back home and pack a bag and get my other children situated. And they said, yes, but you've got to come back the next morning. So I did. And when I got back, I really felt like this terrible sense of, it felt like something was coming out, and they said, well, no, we can't check you. The doctor said, absolutely, you cannot be checked. And I remember trying to speak succinctly. I remember trying to explain this with every ounce of intellectual, communicative prowess that I could muster. I was trying to really sound like I knew what I was talking about because they were just dismissing me, these all white nurses. And so finally, they put a belly monitor around me and they said, you're not having contractions. You're not in labor. And I was like, I feel something coming down my body. So this kid was birthing herself. And her prophecy was that she was meant to be here. It was also that she would come through adversity as well on her way. And I just thought that was the notion of her being, me being on bed rest or whatever. And I figured since I'm in the hospital and I've got almost like 7.5 weeks left before her due date, then obviously, I'm fine. Well, by the time the doctor got there in the morning, they had only given me Tylenol, and I was literally having this baby move all the way down my birth canal to the point when the doctor checked me, her head was crowning. Like you could see her head. She was coming out. And so they rushed me over, and they barely had enough time to give me some medicine for the pain and contractions. And then she was born. When she shot out, I remember the doctor lunging forward. It was like she almost fell out. And so it was just like this great surge that she just shot out. And then they told me that my water had been leaking the entire night, and that a bacteria had grown in my womb, and that she had now some sort of bacterial infection, and that she was going to have to be in the NICU. And she wasn't like weak from her organs, it was from the bacterial infection. And just the stress of all of that, I guess it made my blood pressure drop, and they had to turn the bed upside down, and they almost lost me in the delivery room. And so it was just really, really stressful for her father and myself as well. I remember he was like so scared that she was going to die or that I was going to die. And I look back on that moment and I think, how would someone that didn't have the ability to code switch and talk like they're on the level of these nurses, how would they have been able to advocate for themselves? And would they have listened to me more had I not been this Black girl? The attitude that they had with me was that, oh, she thinks she's a smart Negro, that kind of thing. And they were very dismissive. And I almost lost my daughter in the process of that. Thankfully, she's not a preemie. She's 14 this month, and she's 5'7", and she's on her way to just, continuing to do the amazing things that were part of her prophecy. But I wanted to make sure that you guys knew about that story, and that we do enter into a situation where you're not sure if you should be talking smart so that you can get the attention of the people in the medical community that are supposed to take care of you, or if you should be speaking like you don't know what you're talking about so that they'll take pity on you and just kind of take over and not have some sort of feeling of anger that you're trying to be superior, you're trying to be on their level. Well, that's my story, and I'm really hoping that you guys get a chance to check out Untold RVA. There's a lot of VCU and MZV related projects that I do in our university community, and I'm hoping that you all will follow us on socials as we're getting rebranded soon, and we focus on the historical narratives that have been deliberately submerged from the record that people can engage with without having to read in order to know. So equity is at the core of everything that I do. And I do work with the medical students regularly, once a year with the first year medical students with Dr. Lemay, and with Sarah Wilson McKay, Dr. McKay as well in the art department. And we're doing some really amazing, groundbreaking, innovative work together, help people understand the roots of racism and to have cultural humility in all things that they do. So I'm going to sign out and say peace, but in all things, give thanks, and we should continue to hold up that which holds us up. Peace and love, and y'all take care. Power to the people. May it be so. And this is
I just want to thank Free so much for sharing that story with us. And I see that she is actually was able to join us. I'm so glad she is. So there'll be some time for some additional comments and discussion at the end. Next, I would like to share the story that Dr. Wally Smith, professor in general internal medicine at VCU, has shared for us, recorded.
Hey, I'm Dr. Wally Smith. I'm the Florence Neal Cooper Smith professor of sickle cell disease at VCU here in the Division of General Internal Medicine. And my story goes back a ways, actually, to when I was an intern. As an African-American medical student, we were one of 13 in a class of 165, and it was new to have Blacks in the class. We had been meeting with the dean and talking about issues of discrimination and things like being avoided by the anatomy professors when it came to dissecting cadavers, and feeling like we weren't welcome, and feeling not an atmosphere, a welcoming atmosphere. So I'd already gone through 4 years of feeling bad about the trailblazing place that I ended up in. This was in Alabama. So I need to say no more about the attitudes in the Deep South, Birmingham, Alabama, where the bombings occurred in 16th Street Baptist Church in the 60s, and Martin Luther King, the whole bit. Well, I'm an intern, and I'm at the VA hospital and going in to examine a patient. And he says, "Hey, can you hand me a bedpan? Get me a bedpan." And I paused for a minute and I said, "Well, actually, I'm in here to do an exam on you. I'm your doctor, and I need to talk to you and do an exam." He said, "Oh, okay, well, can you get me a bedpan? Or get somebody to get me a bedpan?" And I took it. I didn't say anything. I didn't tell him I was offended. I didn't confront him. I just went with it. I was the only Black intern in that intern class, feeling lucky to get there, feeling like people were expecting me to fail. And I was doggedly determined that I wasn't going to fail and I was going to get through my internship year at UAB. I ultimately left UAB after my internship year and went somewhere else where I felt a little bit more welcome. But that was one of many turning experiences. Actually, I thought it was implicit bias to put the term on it now. I thought that what he did was what we call a microaggression, but we didn't have words to describe all of that. And you didn't talk about that. You just took it and you kept going. So that's my story.
Next, our next storyteller, and thank you so much, Dr. Smith, for sharing that wonderful story. I'm also hopeful that Dr. Smith will be able to join us at the end for some questions and comments. He's in the middle of a very, very busy clinic day. Our next storyteller is Ms. Kathryn Mejia, who's a program manager at Therapy Brands.
Hey there, everybody hear me? Hi, my name is Kathryn Mejia, and the story that I'm telling today is actually one that happened to my mother-in-law. I did ask her to be here today. Unfortunately, she was not able to get off of work. My mother-in-law is Dominican, and she moved here when she was in her early 20s. She does have a grasp of English, but not quite as much. So Spanish is predominantly the language that we speak at home. And when she seeks out healthcare providers, she does tend to seek out Spanish-speaking ones. So she can be a little bit more comfortable, or she has one of us go with her. In the fall of 2020, right before Thanksgiving, she came down with COVID. And at the time, that was a big surge last year, or 2 years ago almost, that, we kind of did the wait at home, see how she did, make sure she was isolating and following those things. It eventually got to the point where I really felt like she needed to go to the hospital, and it was kind of hard to manage a little remotely because obviously I couldn't go, oh, come get in the van, come with me, let's go to the hospital. She was pretty resistant to going to the hospital, and I had a feeling she was going to be very uncomfortable there because nobody really likes to be in a hospital. But she just said, no one's ever going to understand me. I don't want to go to the emergency room because no one was ever going to understand me. And I'm thinking, well, they have Marty's, or they have ways that we can get you some Spanish translation. We'll have ways to try to make you more comfortable. I would go with you, but unfortunately, due to the nature of COVID, I cannot do that. She did eventually go to the emergency room, and she was admitted. She ended up going straight to the ICU. She was pretty sick, and we had struggles getting in contact with her providers. And then they were also not really letting us speak to her. Their thought was that she just wasn't able to really have the lung capacity to speak well. So we're going a few days without really hearing anything. Eventually, she must have got a hold of her cell phone. She did attempt to call us, and she was, kind of speaking and saying, she had no idea what was happening. Could we help her find ways or figure out what was going on with her? And we were saying, well, isn't anybody speaking with you? Are you able to, get your nurse? We can get your doctor. We can try to see if we can find a way. And they said, no, they won't speak Spanish to me. They won't do it. And I was like, well, they won't. Maybe we have an issue trying to get you so they understand the urgency of the situation, because for her, she was terrified. In her mind, I'm going to die because I have no idea what's happening. I'm in a hospital, I'm isolated and I can't talk to anybody. So I said, okay, well, let me call. And I eventually tried getting a hold of some of the nurses and trying to get a hold of the provider to say, hey, can somebody speak to her, because she's terrified. She's just really, really scared. She has no idea what's going on. The provider completely blew off the situation and just said, well, we know she's okay, but she doesn't know that. She has no idea she's okay, and that she'll be doing a little bit better. Can just somebody speak to her and offer her some level of comfort, because we also didn't know what was going on, to provide some of that comfort to her. We've been having a lot of trouble letting anyone help her kind of navigate her cell phone and help see if we can make a phone call. And the provider said, she's fine. She's fine. Well, we'll make sure she knows she's fine. And then, we tried getting a hold of our nursing team as well, saying, hey, is there a nurse who speaks Spanish? Is there any way we can get somebody to speak to her? I know that we can't go in the room with her, but is there a way that we can find something to help her? And the nursing team was like, well, we'll eventually get to it. And I'm like, okay, well, she's scared, she's terrified. And my main concern was that nobody seemed to be worried about her feelings in this situation. Or as a patient, she's not a doctor, she's not a medical professional, she has no idea what's going on. And I think hospitals are scary for anyone. And not wanting to help her understand what was going on, I think was really hard. And their whole thing was, well, we know what's going on, and if she doesn't understand English, then she'll figure it out. She eventually did get worse, and she was eventually intubated throughout the entire process. Again, no one's really speaking Spanish to her. We did find a cleaning person who was able to tell her, you know, I'm praying for you, I hope you're doing okay, I'll see if I can help you out with something else. But we all know that that's also not a provider or a nurse or anyone who's able to kind of give her this is exactly what's happening to you, this is what's going on. Going through the process of her knowing she was going to be intubated is, again, terrifying for anyone. I think it's more terrifying when you have no idea what's going on. I did raise quite a fuss with the hospital and the nursing team, and I was told everything from, you're meddling, you're getting on our nerves, we don't have time for this. You know, we have to take care of patients, and taking care, and, you know, taking this extra step to help her understand is just not our priority right now. And it really bothered me in the sense that no one thought to look from her perspective. No one thought to look at how she feels in this situation. No one, I'm over here trying to make a fuss on the outside, seeing what I can do to have somebody reach her. Eventually, thank goodness, she did recover. We did get her out of the hospital. She had to be out for 4 months after her hospital stay to recover. And she had to have several doctor's appointments because she did have a lot of long-term COVID complications. And getting her to go to doctor's appointments was extremely difficult because she said, they won't help me. She already had some trepidation going into appointments because she felt like they would never speak to her the way she needed to be spoken to. No Spanish, no one trying to help her understand, which can also be dangerous because she was just given medications like, oh, well, I guess you just have anxiety, here you go, without explaining what the medication was, what it could, you know, was going to do for her, what she may need. But we're still dealing with the after effects of her not being able to go to providers, and her recovery, I think, has been hindered because she's just now completely terrified of seeing providers and going to any type of hospital setting. I'm sorry, I'm trying to keep good with time.
Kathryn, thank you so much. I know we all really, as providers, appreciate hearing that perspective, because I think it's all of us who work in a hospital or a clinic have unfortunately probably seen a situation similar to that. And I just want to thank you so much for sharing that with us today. Thank you.
Happy to. Thank you for the time.
All right, and our last storyteller for today is Dr. Sarika Modi.
Thanks. So growing up, I felt American. My parents came to this country for a better life for themselves and their children, and I felt like we were living the American dream. We had a good life, and I knew a lot of that was because of the opportunities we had here, and also because of the hard work of my parents. I was American, and I knew I belonged. I grew up eating Indian food at home and American food outside. My sisters and I would love when we would be able to eat pizza and hot dogs. And understanding that I was American as much as I was Indian. I'm sure there were questions from my classmates about whether I was a feather Indian or a dot Indian, but I just took them as curiosities and laughed them off. And then 9/11 happened. And all of a sudden, everything changed. We had lived in our home for over a decade, but the day after 9/11, our neighbor came into our house without knocking and walked up the stairs. He accused us of being terrorists. I was 16 years old, and suddenly everything had changed. The sense of belonging I had was shattered. We had people shouting at us that they were going to bomb our country or tell us to go back to where we came from. I no longer felt like I belonged. I think about that time and the realization I had that maybe other people didn't view me as American. I felt lost. If the country I was born in and raised in didn't accept me, then where did I belong? And as I've grown older, I thought about the privilege I had of not feeling that hatred till I was 16. I think about how being Indian in this country has shaped me, and also meant that the view of Indians as a model minority has given me privilege. My path was easier because of those model minority expectations. And I think about the communities in this country who have faced generations of discrimination, who have been told by society that they don't belong, and who have faced violence through multiple generations. I think about how much of an impact that experience at 16 had on me, and my understanding of where society placed me, and the lessons my parents taught us to keep our heads down and follow the rules so we wouldn't stand out and be targeted. And as a physician, I think about my patients, the ones here at VCU who grew up in this community, who have experienced these long history of discrimination in this city. The ones who have been told by society that they do not hold importance or power in this country, how their voice is often not heard, and how we've seen over and over again in medicine, these communities being failed. I think about how someone's power in society can really impact the way they're listened to and cared for, even in healthcare. And I think about a patient I had whose story has stuck with me. He was a middle-aged Black man who was admitted for a pulmonary embolism, and he was started on rivaroxaban. Initially, he was doing fine. I thought I was gonna be able to discharge him the next day. He was on room air. He seemed to have no complaints. However, his condition got worse. His white count kept rising and his breathing got worse, and I was a little worried about him, so we did some scans. The scans showed that he actually had empyema with an infarcted lung and necrosis. I talked immediately with different consulting services because I recognized that this gentleman had an issue that needed some sort of intervention. And I was told that yes, he would have to have surgery to clear this. Every day I would go into his room and ask him if he wanted me to talk to his family and talk to anyone. And he would say, no, I'm doing okay, I'm doing okay. He didn't complain, even as his oxygenation worsened. Even as I saw him deteriorate, he became more tachypnic and fatigued. And I spoke with the consultants multiple times a day, escalating as much as I could, trying to be as much of an advocate as I could. As the plan was agreed to that he needed intervention. However, there was a concern about an elevated INR. He had been on rivaroxaban, which can artificially inflate the INR or basically make it invalid. We had studies that showed that, we had articles, we had our pharmacists also talking to their pharmacists, the consulting team, but everybody seemed to be really nervous about this INR, and nothing that we talked about really seemed to change their understanding of it. As these talks went on, this patient unfortunately kept doing worse. He kept getting sicker in front of my eyes. No intervention was done. This gentleman was a middle-aged, otherwise healthy Black man. And sadly, he coded after several days. He went to the OR emergently, and he passed away. And I thought again about a person's power in society. Wonder if he had had more power, would his voice have been heard differently? Would his conditions have been treated differently? Would the same decisions have been made? And I don't know. Thank you.
Thank you so much, Dr. Modi. Dr. Modi, if you'd like to share briefly with us about the idea of race-conscious medicine.
Yeah, so of course, you know, the question becomes, where do we go? Where do we go from here? First off, I just want to say thank you to all our storytellers. Narrative is such a powerful tool, and I really appreciate that you guys shared with us. I know it's a very vulnerable thing to do. Talking about where do we go from here when we talk about race-based medicine versus race-conscious medicine. So I would argue that we even are operating in this race-based medicine idea. And when we talk today about race, you know, the idea isn't that we just take race away completely, because that doesn't work. Obviously, racism is playing a role in the health of our patients. So we have to really then ask ourselves, what is playing the biggest role? And how do we change the way we think about race? And so race right now, as we see it, is ill-defined, and it's unfortunately inferred to have a biological significance. And then you see research studies that use that as a tenet of their research studies, the foundation of the research studies, and you see results such as the GFR calculator, which links racial specific things to different GFRs. But again, this is all based on an inherently wrong idea that race has a biological significance. And then that's taught in our medical education, and then what goes on to clinical practice, which then also all leads to racial health inequities. So what can we do different? Well, let's talk about what race conscious medicine is. Race conscious medicine is saying, well, let's look at race as defined as it is, a social and power construct. It was created for power. It was created to perpetuate racism. And so these effects of the structural racism is actually analyzed, and we get to the crux of why we have these different health disparities, why we have these issues. And that's taught to our medical students and our residents, who then go on in their clinical practice and really try to tackle these issues rather than trying to use calculators that are based in the old way of thinking. And we can actually reduce health inequities. And that's the whole idea behind that.
So I just want to close today by kind of giving a charge to the medical educators and the audience today that this is our responsibility. Our medical trainees are going to model what they see in their instructors. And it's really our job to understand and individualize our care for our patients in a way that appreciates the real causal factors for why our patients may be experiencing poor health to better tailor our care. If you choose to include race in your medical decision-making, I ask you to ask yourself some questions. How well do I understand the evidence of the perceived racial difference in this patient? Will this result in me treating a patient differently than if this patient was of another race? Does this decision further a health disparity? And how can I acknowledge the impact of racism on this patient's health without implying biologic predisposition to disease? And with that, I will open for any questions or comments from the audience. I also just want to, before we open up to questions, just offer my heartfelt thanks to all of the storytellers today, Ms. Bangura, Ms. Kathryn Mejia, Dr. Smith, Dr. Modi. Thank you so much for bringing your stories to us. I can't tell you how much I appreciate it. Thank you.
Thank you, Dr. Lemay, and everyone. Very powerful. Thank you so much for sharing personal stories. We'll open it up to the audience here. As I alluded to in the chat, you can ask to unmute yourself, and we can unmute you so you can ask your question or use the chat. I'll start off. Wondering interactions with trainees, both Ms. Bangura and Dr. Lemay, Dr. Moody, and Kathryn, you as well. You all referenced a study with UVA students in the past. Are you all aware of any, in the last 5 years or so, current attitudes by trainees? Do they differ by region across the country? Do they differ internationally? If you look at European or medical school trainees in Asia, have you guys come across anything like that? Just wanted to know if you had any comments.
I'll just share my knowledge on this subject. Is the most recent review of biases. It wasn't a repetition of this UVA study, but rather a review of implicitly held attitudes towards Black patients. The most recent that I've seen still maintains that physicians, medical students have negative implicit attitudes still towards Black patients in the United States. I can't speak to outside of the US. That's a great question. I don't know the answer to that. I don't know if any of the other panelists have anything to add to that.
I think, like you said, Dr. Lemay, that there's, I don't know of an actual survey that's done exactly like UVA has done, but there have been lots of studies looking at bias, and I think one of the more recent ones that has been found is that there are links to terms such as noncompliance and challenging things that are coded, essentially coded language in patients' charts that have been linked to higher, these words are used more often in patients who are Black. And so that kind of tells you that there's these negative connotations still there, these biases exist in all of medicine.
The other thing I'll add to that, just since today is a storytelling grand rounds, is I think if you ask Kathryn or Free, you know, they're about our patients' personal experience with interpersonal and systemic racism in the medical community. I think you will find that in 2022, you will find an infinite number of stories of patients' personal experience of continuing to experience racism in the medical setting.
Hey, everybody. This is Free. Thanks so much for the gracious welcome today, giving an opportunity to share. To answer your question, specifically what you just said, Dr. Lemay, do you remember when we had the students down at the Civil War Center this year? Her first year medical students with Dr. Wilson McKay come with me to do a site-based exploration of different perspectives and cultural humility within their first year getting started in medical school. And I remember after sharing, it wasn't even about this particular circumstance, but quite a few students, as we were walking through Browns Island, came to me and said, and even some wrote to me afterwards and said that they also have had experiences with their families as they are from different cultures than the dominant culture here in the United States, and that their parents had been, on their deathbed. Had it not been for someone in the family being medically trained and stuff, they would have died. And one of the things that came up in our discussion was that we're now getting to the point where people are aware of the racism that pervades within the system, but it's like a hesitation to call it out. So when you're experiencing someone treating a patient in a way that's disparaging or that's risking their life based on race, the students are now just starting to begin to broach the place where they can call it out and be like, that's blatant racism, So I think that's where I'll say, yes, we should congratulate the movement that we're all a part of in being able to push the needle forward, move the ball forward. But we still are, I believe, falling short of calling out what we're seeing as blatant and giving people the benefit of the doubt. And in those moments, like the young woman that presented, the young person that presented just before me, or maybe after me, said that those critical moments can mean life and death, So maybe if it had been called out, it could have saved his life if it had been as urgent as this is a racist act. So I wanted to just bring that forward. We have a lot of work to do.
Thank you so much, Free.
Any other reflections, comments, Dr. Syme? Any thoughts from the department?
Yeah, no, thank you. I'm sorry, I'm having trouble getting off on my camera for some reason, so apologies. But I wanted to thank everyone for your honesty and for the presentations today. And I think you made a great point, Free, is, I think we've gotten better at recognizing the problems, but not in offering people immediate solutions in the moment to handle this. And I do think that's something that as we're practicing in our own clinics, but also modeling for learners, how do we help people, and how do we help people enable other people to call it out and handle it so that it's, we can move forward. So I think that was a fantastic point you made, Free, and I couldn't agree more. It's gotten easier to identify. I think we have gotten better at that, but your point was good. We still have a long way to go, and just enabling each other to call things out as we see them and offer solutions. So I think that's a great way to end.
Thank you, Dr. Syme.
Thank you all so much. It looks like we're at the top of the hour, so just on behalf of the Department of Internal Medicine, we just want to thank Megan Lemay for bringing everybody together also, and Dr. Moody. Dr. Wally Smith was unable to make it today, but we want to acknowledge his story and presence, and want to thank Ms. Kathryn Mejia and Ms. Free Bangura. Thank you all for sharing your personal stories. So again, the link to the content will be online. Really appreciate it. Thank you so much. Dr. Lemay, any last parting words?
No, I just want to thank our storytellers again, and thank the department for allowing us to bring this to everyone today. Thank you so much.
Thank you so much. I hope you all have a great rest of the afternoon. Thanks for your time. The CME code will be on the screen here in a few minutes. That concludes our grand rounds. Thank you so much.